Let's start with definition. That's the lawyer in me. We say universal free healthcare. Most of what we hear and read in the press is not about healthcare at all. The term that they choose to use is very scary. Universal health coverage. So they really don't want providing health. They want to sell you insurance. It's very important to understand the difference because it's commonly used and it's easy to confuse. And if you start listening to coverage over a period of time, start thinking that you actually get a healthcare service. So the first to remember is that you have to be clear and be vigilant at all times to focus on healthcare. So everybody having health insurance doesn't actually getting health care. Yes, it really means that having insurance actually doesn't make you worse. You need a doctor to provide health care, not an insurance company providing insurance. Two separate things. Most people think that if you have insurance, we can naturally get health care. Not true. Because two aren't connected in most parts. Also in India, non-life insurance market is 1% of the population as non-life insurance. So the penetration of insurance in this country was 1%. It contributes to very little of the care expenditure who's going. Another requesting what to those who are interested in this is to look at the economic survey, national health surveys, which tell you what the total spend is in terms of total care expenditure you get, and who contributes how much to it. Can someone guess who's the largest contributor to healthcare expenditure? Who pays the most in this country? No, not at all. Insurance companies pay the least. In terms of size, we have 1 lakh, we have 1 lakh crores in total health expenditure in this country. No. Sorry? It's not government, it is?
Our sons. You pay by our sons.
Yeah. We pay the most. Indian citizens pay 63% of total health care out of pocket. Everybody else put together is less than a third. So let's start with that. Despite what you hear, we're all paying a large amount of money towards healthcare expenditure. Government is the second largest. And when I mean government, I mean every part of government. CGHS, ESI, public sector undertakings, group insurance schemes of government, all of those things put together are not even a third. Insurance is simply it. So it's first important to understand what the market is, what our perception of what is happening, who's paying, who's making the money. Of this total debt expenditure, we are paying the most. Everybody is paying by. Who's actually making money out of this? Is the next thing you think about. Yeah? So we are paying the money. Who's getting all this? It's not government. So what is the government doing here? It's taking money from us and giving to private operators. All the while you are picking the government providing you health care. So please keep this in mind for at least half now. To understand what is this all about. There are lots of myths, lots of very nice sounding words, like people wearing lab coats and suits, which kind of confuses us a lot. And more you read, more time it takes to remember that, no, that's not true. So there's a lot of it. When you read the papers, you read politicians speaking about it, API speaking about it. So please stop it, think, what is it that they're selling? What is the idea? What are they trying to get? And why are they using the word coverage as differently than care? Where is the health care part? Care part is that I get health care services. Coverage is where is any insurance. Okay? So that's really important to understand this. It's not a new idea. This idea existed around the world long time. In fact, it was one of the key aspects of the Indian administration during the tail end of the British rule. So strangely, the Brits had no interest in us having universal free healthcare. Think of the IVDO. The Brits, I think 46, had a committee report saying it's important for Indians to have free healthcare irrespective of income. In 1946, it's called the Boer Committee Report. Most of it is available. And this was in 1946. So this is a colonial power saying that Indians should have free access to healthcare irrespective of income. Which you think is a very radical idea back in past. And much of what came out as the SDGs and all that, you can trace back and say this is not new idea of having the SDG. In 1946, this is what it says. What is Thailand? Contrast in healthcare expenditure at that time. For Britain, it was 20.4% in 34-35, 30.8% to the United States. This is expenditure on healthcare. Now we are fighting over whether it should be 2%. This is the healthcare expenditure of Britain and the United States in the 30s. The recommendation at that time in 1946 was that a minimum of 15% of total expenditure should be for healthcare. 1946 is what the recommendation for all governments. And don't forget, sorry to push you a little bit on constitutional history, in 1919 there was a devolution of powers under the 1919 Government of India Act. And those of you who have a little bit of history will remember the Montague sort of reforms. At that time, provinces got authority think about and talk about public health. So there was already a devolution at that time and continues to this day. So health, public health, still a safe subject, right? And the recommendation then was to allocate a minimum of 15% of total expenditure to health. And an annual per capita expenditure of 71 rupees 87 paise. It's a significant amount near that in Naki per acceptance. On recurrent costs and 1 rupee 11 paisa on non-recurring expense. So you're thinking about how they are conceding the breakdown of revenue expenditure and capital. Aiming not to exceed 1.33% of the gross national product, as they say the gap perfect. We are nowhere near this number really. So let's ask the question, right? We have this idea 80 years old. The rest of the world took this idea out. So at the same time that this happened in India, there was a similar report a few years later in the UK. And that will get birth to National Health Service, which did exactly this, which took the idea and said everybody should have access to free healthcare services irrespective of income. In the government, you set up hospitals, pay doctors, and ensure that everybody has access to pay healthcare. So, much of what I'm telling you is not new. So all those of you who came to listen to something interesting and new, I'm sorry to disappoint you. This is all old stuff. Now let's see what has happened since. We had this great announcement. We had some benchmarks. We had some objectives. We had some targets. How many states do you think you will allocate 5% index? Yes? How many states of all the states in this country? How many allocate 5%? 13 was the target. How many allocate 5? Experience. Go. No. Get the guess. No. Kerala, very good. One. And then?
Yeah.
Tamil Nadu. Goa. So we have a total of 5. I think 2 is Rajasthan and 1 now. So we have 4 states which allocate 5% of their budget to healthcare. Vast teacher then agreed to 3. It's about approaching 4. So these 4 are there. It is okay. Yeah, at least got 5% of their budget. Then you have to ask the question, how many can spend that funds? So, in every other department, they spend more than budget. Okay, look at the end of the following year, you look at what has happened to the expenditure, you'll find that a lot of them exceeded their original budgets. Sometimes they will get some grant, will have an additional grant, some additional expenditures approved, all that, except in health, where most of the years they not even spend 80% of that 5%. So when someone says we don't have the money, you're not even spent what has been budget. So we have to ask the question why? Why is it that you don't allocate money? And once allocated, you don't spend the money. It's not as if you don't need it. So what is happening in this system? So every time somebody says we lack funds, our first response should be, you expect what you have. You can't come to me and complain until you run out. Why start taking until you're down to the last penny? So, what is the challenge for us? Challenge is not money, EAP now. Because there is money and they are not spent it. So, nobody can complain that we don't have money to spend on healthcare. At least there we have it. We are not spent. Then look at who has ideas on healthcare. What are the government's ideas on healthcare? For many years there. The two great concepts they take off is affordability and accessibility. We'll get to all the time in healthcare. Is healthcare affordable? Is it accessible? Very often they confound the two terms. When they mean affordability, they use accessibility. They think it's the same. If medicines are cheap, everybody has access to them. No, medicines are cheap. Actually, fewer people have access to them. Because that's how economics works. They reduce the price, reduce production, therefore, fewer people get it. But clearly, that's not how our policymakers think. But I'll come to this. Then we say, oh, we have to use access because you've got PHCs, you've got government clinics, government hospitals, people are using them. And we have some excellent funds. So, those of you who haven't visited a BXC should visit a BXC. There's some really good ones. Goa has some really good ones. The hospitals may be terrible, especially the private hospitals in Goa, but the BSc is fantastic. So, you know about Marga, you know these places, it's beautiful. Similarly in Kerala, their staff will actually have people there. There is a doctor there. You do not wait very long. So I've used the one Marga, I've used the one Nasarao, I've used the one near Moira, I've used the one. Few of those places in North Goa I had. And perfectly acceptable doctors, very sensible prescriptions. Doctors were not trying to sell you anything and are available. And my wait was never more than an hour or so, which anyway I would have had to you in the private hospital. So there are some parts, and they may be biased because I have been to all of them. But by and large, my sense of how it spoke to people in these two states is that they're very accessible. You have doctors. They are there every day. You can even go during an emergency. At least there will be somebody there. There will be somebody manning that place. So there are, but that's not true of most of India. So we have places like Bihar and MP which have no infrastructure. You actually spend less. So if you see a per capita expenditure on healthcare, Goa has the highest, when actually needs the least. Zodi has a boyfriend. Bihar and UP are the least, and they spend also the least for it. So you understand cabbage. States that need it the most, need to spend money more, actually spend less money than states who need to spend less, given that they're already quite vast. So again, when people say, oh, we don't have the money, you just look at it and say, why can't UP spend per capita as much as Kerala for? Then you talked about, so look at what a fantastic job we have done with ASHA workers and Anganwadi workers. Then you ask the question, yeah, really? What's the time? Why are they on the streets? Why are they constantly striking? Why are they unhappy? Because we don't treat them like professionals. Great idea, great concept, badly executed because we don't value professionals. If we told them, you're professionals, here are our objectives, no often do it. And we pay you a professional wage for it. Then you get them to. Instead, what we tell them is their work is voluntary and they are paid an honorary. And then they're going to be harassed with, here's a pack, you have to mark attendance on the app, and then you have to geotag every place that you go so that we know you actually visited. So we're giving them lots of tasks to do, but not treating them like professionals. And a lot of their complaint is that they are doing more administrative tasks than actually providing healthcare services. So there's so much paperwork to be done. Instead, if we told them differently that, hey, we will judge you on the health performance of your locality. That's enough, right? What you want is good health outcomes. Instead, what you're getting them to do is none of useless tasks. So again, great idea, but we made it to a mess. Similarly, you government hospitals, which we think are terrible, and we think, we should now have private entities running these hospitals. And you ask them, if the private hospitals were so good, why is it that those have a choice between government hospital and private hospitals? Look at the government hospitals. When was the last time you saw the Prime Minister of Brazil in a private hospital? Did it occur to you? Why does the president go to a public hospital? Why do all MPs go to public hospitals? Why do all MLAs want to go to public hospitals? Why do all IAS officers want to go to public hospitals? What is the no public practice? Have you noticed it? Prime Minister is assassinated. Where do they take? Sonia Gandhi is not well. Where does she go to? Gangarap Hospital. Have you ever heard of them going to Fortis or Kolkata? You may be friends with Larry Strand, but you're not going to his hospital, right? It ever occurred to any of you? Why is it that those who have access to all hospitals in the world will choose government hospital? Is it occurred to you? Shouldn't you be thinking about it? The private guys are so good, and we should ask them to run private hospital. Shouldn't we ask this question? If they are so good, why those who can afford it and want the best go to those hospitals when they actually come to the public hospital? So there's something wrong. And that wrong is our perception of these things. That private hospitals are better than government hospitals. And there's a reason for this, right? The reason is so that we can get all of you come to private hospitals. So if you rubbish the public hospitals, we can get all of you come to the private hospitals. And say, look, there's this beautiful hospital, spanky new. You have an app. You'll be served coffee downstairs, and there's a cafeteria and a food court, and maybe a little band plays there. I don't know. And you'll have a crash, and you'll have daily places and all that. Is that the health kit? Go to a mall for that. Why would you go to a hospital? So you have asked this question. Then government says, we're really very interested in healthcare. We're given grants and incentives for private players to build hospitals. So if you look at all the private players, they've all been given grants. So they have when they say we are a private entity, it's all private capital, risk capital. More than 50% of it is actually government grant. So they're lying the speed. They get tax benefits, all of that to build the hospital. So, again, when people say private enterprise, highways, really? 50% of it was government. So you got to benefit 50%. What have we given back for it? Even when there be conditions for those 50%, it is that you will allocate beds to poor. You ever see poor people in a posh hospital? No. This sort of lot stacked. And they managed to kind of fall into one of those hospitals. There's no chance they're going to get a bed, they're going to get any service. So again, you would ask the question, has that government policy of giving grants, incentives, tax breaks, free land, actually resulted in healthcare for most population? The answer is no. Then we have the wonderful thing, PMJ. Everybody gets a card. And that's a scam for most politicians nowadays. You tell someone, you got a card. Aadhaar card. Blue card. Green card. Below poverty line card. Farmer card. No, ration card. Kerosene card. Give everybody a card. And most people are very happy that they bought a card. As if the card is that taken to him. We're all very happy. And he got this thing done. Fantastic. It's a scan. Beautifully done. Enroll people. People will stand in queue for days or end, weeks on end to get a card. Card actually doesn't do a service. But everybody owes that if I get a card, then I can't be denied a service. So we'll sell you next card, one more card. So every few years, we will create one more card to say, okay, you got this benefit. And that's a very good scam. But here's the interesting thing. The PNJ cow is for 5 lakhs owners. Can someone tell me how much it costs in per year? You get 5 lakh to show this cow. Take a punt. All of you must know.
Depending on your age, but like for example, my age, it would be somewhere around 5,000-6,000 rupees.
5,000-6,000 rupees for 5 lakhs, right? What does it cost PLJ? Yes, it's more or less. Come on, some economics, some insurance idea, risk pooling. How much do it?
Okay, Ramdan rupees. I'm taking a full guess, 200-300 dollars.
Okay. Think you're paying 10 times what you should be paying.
But
You know that Anindi I do. Take a guess. So it costs PNJ to provide 5 lakhs of health cover to a family, 1,052 rupees. Please keep this in mind, the number is very important. For 5 lakhs of cover, it only costs 1,050 rupees a year. So I believe your ideas. What does it cost the government to cover everybody? Get good insurance. To get real health care. In the comparison I give you, how many of you own vehicles, drive vehicles? Yeah, very good. You have insurance, right? All of you have insurance. If you rate your insurance policy, you should. Because the one important thing to figure out there is what it does not cover. Can someone explain to me what your car insurance or bike insurance does not cover? You remember? No?
so it's not driving. If insurance is in my name, someone start driving, then it doesn't cover anything essentially, right?
If you don't drive, you won't cause an accident, so there's no problem.
It does not cover life.
Does not cover life.
Like this, instead of
Sorry, say me? It doesn't matter. If you're sitting in the car is covered. Everybody in the car is covered. So the insurance attaches to the car, not to you. The insurance is for the car, not for me. So everybody who's sitting in the car is covered by the insurance. And everybody outside the car who's elected by the car is also covered by the insurance. Yes. Say again? Yeah, so everybody mostly has comprehensive insurance. The low level of it, which you can't afford the comprehensive, is just had third-party cover so that you're not covered. But most people will have comprehensive cover. And frankly, it excludes nothing. So here's the funny thing. You can buy insurance for your car that covers dents, nicks, scratches, everything. You can't have insurance for yourself. Medical insurance that covers everything. Isn't that weird? Is the car more precious than the person? You don't find states that you can buy comprehensive insurance for vehicles. But 80% of the things you're going to need health insurance for is not covered by health insurance. Shouldn't we be on the streets writing about this? What kind of insurance is this? It mostly excludes. Very little that's covered. Look, you should please all read your insurance policies. I know it's not interesting, but please read it. It will cause you some health problems. Just read the insurance policy. You should read it. So this is a government certain thing that what have we done? You give an FP or PNJ cow, which taking news to go for hospitals. And the reality is that even if these people went with the car to the hospital turned the body up. So here enough stories about the fact that hospitals don't want these people because they don't think they won't be treating these patients. It's very hard to get money from government. So they just make up PNJ patients much easier. You just make up Ram, Raji, whatever. Hundreds of them. Submit the bill to government. You get paid without having any rare patient. So they found, hospitals have figured that out correctly. That we need the PNJ scheme, but not the PNJ patients. So there's massive fraud happening there. But the outcome of this is that, and this is the main part of what I wanted to say, the outcome of that is that we now have somebody with significant market power. So large purchaser, the largest purchaser as a block, being able to set prices. And to me, this is a really important role of government. That government as a significant player in the healthcare market, as a purchaser, can set prices. We'll come to this. Then we have the Jan Aushadhi stores which will send you Cheeto mixes. And then we have the drug price control portal, which is one of my pet peeves, where the government says that we will control the prices of essential medicines. And you think, essential means things that prevent you from dying. That's how you think of essential. Essential for life. But if you see that list, they're mostly cough and cold medication. So here's the government saying, you can die of cancer, but we're very worried about you having a cough and cold. So the essential medicines are things for fever, cough and cold. Those are the kind of things, largely. There are also some diabetes and hypertension, but not cancer. Because you may die of cancer. So we don't have price control for that. Also, we don't have price control for patented products. So now, those of you who are studying economics, this is a very good question. You have a situation where there is an extremely competitive market. 200 producers of a product. Yes. So we would agree it's a very competitive market. So there are 200 producers of the product. In that market, you will have price control. Because we don't. But for a patented drug which is a monopoly, you don't think we should have price. So any students of economics, a fantastic paper to write is how do you make economic sense for the fact that you don't want to regulate the price of a monopoly, you want to regulate the price of a competitive market. I'd like to hear a theory on it. So somebody wants to do a PhD. It's a good one. What is the economic basis for controlling pricing in a tight, competitive market, but not from now? It's a very interesting one there. I'd like to discuss that when we get to it. So what is the role of government? Why I think government is very important? I think of government in three different roles. First and foremost is a market player. It provides services. It has hospitals. It has pharmaceutical companies, legacies that lease drugs. And they're going to pay in the market as a supplier of goods and services. It's also a payer. So, the largest chunk where government pays is through all its schemes. With the CGHS, ESI, Central ex-servicemen, ECHS, something, railways, all of them have free healthcare schemes. By which they can access any private hospital or public hospital. So it's a pair. On hand, it supplies goods and services. Second hand, on the other hand, is also pay. It can be a regulator if it chooses to. So it has a power to do it, as I said. For drugs, it does price control orders. It regulates hospitals, just those. But does it very carefully? So if you think of the government, each of the schemes is run independently. Which means that they all set different prices. So the price that the government is willing to pay for an employee of the CGHS to get surgery in a hospital is different. For the exact same service that ESI pays to that cost for that service. Same thing with drugs. So I have paper out last year where we compare. What does it cost EHS to buy it, ESI to buy it, CGHS to buy it, General Shruti to buy it, railways to buy it, state governments to buy it. They found out that we same drug at what price. So this is the failure of government. These two can do a secondary market player is to indicate price. And we do it for everything else. We do it for onions. You notice? Onion price goes up. What do? They ban export. And shove a whole lot of onions into the market. Issue an order saying you can't stockpile, you put stockpiling norms. You can't stop more than X amount of onions in your warehouse. So that there is a onion flow back into the market. It does that for currency. Yes, the RBI buys and sends currency so that we can keep whatever rate they're told should be the fair rate for the Indian rupee against the dollar. Does it there? Does it for money? Does it for onions? It does it with MSP. It indicates to the market what a fair price is. And generally the purchasing is around the MSP price. Therefore, it's possible for government. It does it for onions, does it for food trays, does it for the dollar, does it for interest rates. Whatever interest rate the RBI sets as the interbank rate, you put it, effectively becomes the rate around which you and I borrow a rate. So it does it for everything else. Why can't it do it for healthcare? So if you see what I would say government should do, this is one of the things you should do. And again, I'm not asking government to be a regulator. Again, I'm not a commie, right? I'm just saying you're a market player, behave like a market player. Behave like an adult in that market. What are you scared of? So what is my motto? My motto is basically simple. That we have the CGHS, which is the universal free healthcare service. It's only for the privileged. No, IS officers, central government employees, all get free healthcare for life, for self-employed family. How much do you think it costs the government to provide CGHS per person per year? Oh, take the test. Insurance costs 1,000. Actually providing the healthcare, how much do you think it costs the CGHS? Take a punt. How hard can it be? 1 pizza, 2 pizza, 3 pizzas. How much does it cost? No? It costs about 5,000 rupees. 4,853 or some figure like that. Now you have an indication that if the government spent 4,000 for the 80 crore people who can't afford it, but clearly can't afford it because you're giving them free grade, right? So that's number one cost. And very strange, if you go back and read the economic survey, that's exactly the amount of the out-of-pocket expenditure per person. Is about tiny number. So the two tally, what an individual spends, you and I spend on average over a year. If you divide total health expenditure divided by the population, it comes to over 5,000 rupees. So it should tell you what the costs. I need to see how do we verify that is the cost. You find how much the CGHS pays per person per year. It's about the same number. So what is the money you have to raise now? 5,000 pints, 80 crores. Yes, everybody clear? None of India is a poor country, we can't raise that money. So here's where I found the monetary. The ESR. Everybody aware that there is something called the employee state insurance?
Yes.
Who pays into ESR? US team ESR? Right. Who's employees? It's called employee state insurance. Employee state insurance. That should give you a clue.
Yeah, it goes from our side here.
Yes. And who's eligible for ESR? Who pays into ESR?
Certain salary.
For who? For the lowest form of workers in an industry. to be eligible, there is a limit. You have to fall under that limit. So here, the poorest in the organized sector who are eligible for ESI, and there also there are conditions. You should be in industry, that should be notified industry, you should have more than 50 people. So again, you're getting to a stage, there's a very small number. They've all been paying 3%, 4%, whatever it is, and their parents pay. So you collected money from those who can least afford it. Yes? What have we bid for that? How many ESI hospitals are there in this country? Not many. Have you seen one in your locality? Exactly. So how much money do you think there is? You've collected from all these people, right? How much? Take a guess. How much money is there collected by ESI sitting and doing nothing? I'll tell you what it's doing, but how much do you think? Some guesses. It's been there for 100 years. ESI has been there for 100 years. 13.5 lakh crores. Remember, I asked you to multiply that 5,000 by 80 crore. What number? So I have now found you 13.5 lakh crores from people who have paid for healthcare, got nothing. You got that money. You're investing it in companies in the stock exchange. You're investing it to LIC. Money that the least who can afford it have given it to the government. This is what you're doing there. How many hospitals can you build with 13.5 lakh crores? Just imagine. Or people's money. So, some gift, as is all normally quoted. It's people's money, which is already there. You don't have to collect anymore. And Rupa will tell you about the other places where there is lakhs of crores today. For migrant workers, you collected. Construction workers, you collected. For mines, you collected. So lakhs of crores, right? Lots of places. How many hospitals do you think we can build with this? Quite a few, right? It's more than the market cap of all the healthcare companies put together. That much money we have. So why did we do this? So again, for my model, when people say India is a large country, India is a poor country, where is the money? Staring you in the face. Money is all there. You just choose not to work. Okay? So we've got all of this money. And then we say, yeah, but you cannot be enough. It still not be. Because it takes time to build these hospitals. What can we do before that? Answer is, if you just collapse all these fantastic schemes into one, the savings you will get from just collapsing all these schemes administratively will pay for 10K meals. We did a study just published last year and worked out that if we just rationalize the schemes, got one price and bought supplies to one supply chains on then these 5 different days of getting to the same hospital. Don't forget, in each of these schemes, they are buying from 5 different people, same question. In the same hospital, buying from 5 different people through 5 different routes. There's no sense. Where would you use it? If you got all of them which is supplied directly to the hospital or the PHC to somewhere else, how much money will you save? Okay, so that's a very simple way. The next two, first was price, second was supply chain. And people saying, no, it can't be done. There's a Lancet paper that came out from the National Cancer Grid year before last. They're not a very big organization. They took 23 institutions across the country and identified 40 drugs. Okay? Small program. Their budget, which they spent last year, was 15 billion rupees. Convert that in further. The following year, they decided they would together buy drugs and they would negotiate the price of drugs. Only drugs. Only these 40. 23 institutions, 40 drugs, which they were paying 15 billion. Anyone guess what the negotiation came down to? How much did they say? 5%, 10%? Fine, give me numbers. Outlandish numbers. What do you think they could have said? Maximum. Impossible to say beyond. Come on, give me numbers. Be brave.
He's
Not brave enough.
55.
More. Create. Come on. Kill it. 83%. They came from 15 billion to 1.3 billion. Just 23 little places on 14 drugs. Now, we have government buy thousands of drugs. Got 50,000 cost. Give you some sense of how much money you save? Even if you don't make 83, you'll make 50 at least. You'll make 20% plus you don't have to have a supply chain, get rid of the supply chain. So 80% is not a hard number to crack for government. So where did the money come from? Now, this year. I'll give you money this year. I'll give you 50% more. As if you've done 50% more in your budget this year. Not in 10 years' time. Not while the hospitals are being built. Give you the money this year in sheer savings with no impact certs. We'll still get the same drugs. We'll get great drugs. We'll get better for us. The supply chain is better, quality is better, price is better. We'll get better drugs. So I solved your problem. What can we do till the hospitals are ready? I'll give you 50% of the money you're spending now for free. So your budget is increased 50% or more from your current state. With that, can you not serve more people? How hard can? Then I had this question, Europe, how many the government will be doing this? Which, all I can say is, we're not nationalizing that day. Commies could work on nationalizing that day. I'm not nationalizing. I'm just telling you, play in the market. This is the exact purpose of being a commie. I'm a free market liquid. I'm saying government behave like a market player in the market. How much more free market can get tell this? And that's the answer to that. I'm not nationalizing anything. Government decides to spend money, hospitals will get paid. So that's how the market works. Create demand, supply will catch up. Government sets price, the whole market will get too close to that price up. You are taking it. And then I'm asked, Europe care for the rich, care for the poor. Well, that's really a part of government, isn't it? The rich can care for themselves. You actually need government to care for those. Government doesn't need to care for the rich. The rich can teach the government a few things. The government can teach the rich anything, right? So you shouldn't really worry about the rich. They will have a market. There will be people who are willing to pay an enormous amount of money. And there will be people willing to address that market. And that market's well against today. So we don't have to think about it. The rich find cases to get healthcare. Except Puerto when actually it kind of flattens it, right? 2D equal more or less will go away. So model essentially is this diabots. We have covered head ski. We know what it costs. We get everybody into it. Those who can pay will pay. So depending on your income, you'll make a small contribution to it. Those who can't pay, which are the poor, the lower income, and below the popular, they don't have to pay for it. Because your consumption, don't forget, cost is only 5,000 rupees a year. So when the rich are paying 50,000 rupees, they can afford to take care of 10 others. And that's pretty much the ratio, right? 80%, 20%. So you should be able to get free healthcare for all. And when I mean free, it doesn't matter what your income is, you get the same level of service. You should be able to get it in the same quality as it is. And to everyone who says, oh, it doesn't work anywhere else in the world, oh, they are small countries. Actually works very well in Western Europe, works in Thailand, which is not a Western country, not very rich, works there. Works in Singapore, rich country, but not Western. And there's no reason it can't work here. So rather than say it's a big old idea, and therefore it won't work, it's a big bold idea that's working. So I will leave you with this. Happy to answer any questions that you may have. I have plenty more resource.
So, yes. when it comes to PNJ.
Yes.
Should that hospitals recuse?
Yes, yes.
So what are officially the reason why they
Yes.
sort of so what are the official reasons they give to?
They don't have to give a reason. Because if you get people line up at the hospital and then you go to register, you will have to give your PNJ card. They just park you there, keep you though. After some time, to give up to more. They will be hiding. They don't give you any reason because they're not about to. Who's there to fight their cause? Is there somebody there in the hospital? And don't feel it. Officially, there should be. They have that, I don't know what name they give it. So many acronyms these days, I don't remember what's their part. But there's some Mitra something who is meant to be sitting there in every hospital. In every hospital. Who's supposed to be helping these people. But have you ever seen one in any hospital? That is why they can't get it. When they get frustrated, you go back and ask. Let's say, yes, we will do it, but it will not get covered. So you have a choice, either pay for it or to go somewhere else. Or they will say, we're not covered by cage. Because it doesn't say on the hospital. Have you seen any hospital where exercise is covered by PMJ? So people don't even know they can go into this hospital in their PM. So if you want to know how they're excluded, this is how they exclude. You don't tell them where it is. It's a big secret where the PNJ hospitals are. In case they somehow figure it out. Imagine how. Person below the poverty line is going to figure out that this hospital is covered by PMJ. What is the chances of that? Presuming somehow they figure it out. Then have somebody working there. They go there. This is your first problem. You're excluded. No, we're not covered by PMJ. And you have no way of showing them that or fighting with someone who say, yes, we are covered. Okay, we are covered, but this procedure is not covered. The patient doesn't know whether sucking is covered or not, right? I find it difficult to find on the website what procedure is covered. Anyway, it does not cover outpatient care. So you start from there. Where does it start? You go to a hospital, where do you start first? Either in emergency or in outpatient. That is not covered by PNJ. So you have to hand over money for a service that you may get in the future. Do you try? So that is how exclusion is done. But on the roads, if there are records, we are treating thousands of PFJ patients and sending invoices to government. And they don't even care about. We have dying with cesareans. That's the stupidity of the fraud. I'm not taking this up. These are real stories. This is absolutely real. You have pregnant men who have steroids. And we pay our cats to be injured. So, yes, this is our point. That on both sides, whether you're government or you're a carry entity or below it is, you have no interest actually providing us. We want numbers. So 5 crore people have got PNJ card today. See some mercy. That's a car. Doesn't mean they got a service. The other thing you will see is so much money spent on PMJ. Okay, you spent the money in private hospitals as what? Where is the healthcare? So we have, what we are measuring is metrics, like cards. People enrolled. 100% enrollment, 110% enrollment. Then you got how much money you spend. What are the outcomes? Is it actually making us healthier? Happy or never answer. Because I'm never the purpose of PMJ. You all have to understand that PMJ was set up. It was not to provide healthcare. It was to provide insurance. And they hope that you will take the insurance. And what is insurance for? Insurance are for catastrophes, not for everyday problems. So PNJ is only supposed to be catastrophic health insurance. But if you see what it covers, most of our expenses are things that's not covered by PNJ. Diagnostics, outpatient treatments, chronic diseases, people will take medicines every day, asthma, blood pressure, diabetes, those are not covered by THA. If you break the leg and you get to the hospital and they need to do surgery, and you're lucky, PMJ covers that. If you need heart surgery in a government hospital, PMJ will pay some cost of that. Most of the hospitals, the amount is so small that it doesn't cover chemo. So you can have 2 cycles of chemo, after that, sorry, you've run out of. So those are the challenges, that because of the limits and because of the price, money runs out very quickly. So patients actually, unless you're in and out and you get lucky, you know the doctor and the MLS prank or something, some chance that you will get some treatment. The hospitals have, actually the incentive is very skewed. They are incentivized to make money or take actually useless. To no speak to, I'll give you examples. What do you think in terms of procedures is the most in the PNJ? Which procedure has the highest rank? Like, let's say liver transplant, kidney transplant, brain would be next. What do you think is the procedure that ranks the highest? Most procedures, most amount of money spent for any procedure. Just one or two you can think of.
Angioplasty.
Oh, you have good heart. It remain that way. No. Good one. Next.
Portiotta.
No choice. But it's a good one. For another reason, I'll come to that. Cataract is the first one. Cesareans and hysterectomies. Now you have to think why. Because, sorry? Choices. For a woman having a cesarean, being forced to have cesarean effectively. The hospital makes a lot of money in cesareans, whether they are performed or not. And they are very difficult to actually trace and figure out and audit. Likewise with hysterectomies. So, just make up lists as you perform these bills. Very easy to make money. Second, and this is where we have thought through incentive, right? The ASHA workers are incentivized. They're given 3,000 rupees per event. If the woman delivers in a hospital, yes? So, the hospital is then incentivized to have the woman deliver babies. The ASHA worker to bring the woman to deliver kids. And then we tell the woman that she needs to pay for not just this, but for a whole lot of other things. So you brought in a patient, thanks to the ASHA worker. You're incentivized to perform only a cesarean. So even if it's perfectly reasonable to have a natural birth, what is your incentive as a hospital? To make it a cesarean. Therefore, the growth rate in procedures in India is the highest for cesareans, not for angioplasty. Likewise with hysterectomies. So we have young girls having hysterectomies. The easy way to pick one. So we have late teens, in their 20s. Everybody has hysterectomies. In the old days, it used to be sterilized extras. Those do cheap. Now we have hysterectomies. So how you incentivize? How you think about changing behavior with incentives or triggering certain behavior incentives is really important. And we have thought of that very well. So rather than incentivizing natural birth, we're incentivizing cesareans. So we have a lot of unnecessary procedures as a result of that. And obviously patients don't understand, right? The doctor says, we tell cesarean. And during that time, when they're having cesarean, you're also sterilized. So speak to a lot of the women. It's a very common problem. And it's a really difficult one from a moral standpoint to say whether it's a good idea or bad. Did the woman one day, is it good for her? Should I decide if it's good for her? Very hard to say. But it happens quite a lot now. So it's got some landing pace. So yes, so exclusions, consentives, this is the story. There's plenty written about. And it doesn't tie back in the kind of media you guys read perhaps, but there's plenty of people quite a lot. There are good studies done on exclusion, there are good studies done on incentives, how it's unwrapped, on fraud, because again, you incentivize you fraud in these kind of measures. So there is a way forward. It should get better. The government says it will digitize all our health records. All of you, I hope, got vaccinated during COVID. Yes. And all of you use Aadhaar for that? Yes?
Yeah.
Even though you had a choice of not using? Oh. Sorry?
We made a choice.
We take it choice. You could have given your PAN card, you could have given your driver's license or Aadhaar. You all chose to give Aadhaar. And as a result of that, all of you have a unique health ID. You see your certificate with Modiji's picture as unique health ID. So now, someone somewhere can now start tracking, and therefore, the basis is that now you can go to any hospital, all your health data can be recorded against this unique health ID, and everybody in the world can have your health record. That's the purpose behind having it. So, if you want to look at access, how difficult it is, how the poor have access to health records, what will they do, can they go to any hospital? This is meant to be dealing to all that. And you have a national health, Ayushman, national digital health, something like that. Right? These things kind of scare me every time. Too many letters, too many mission, Yojana, IO, all these things. So there is one whose whole purpose is to digitize Skype IDs. That's good. Hopefully, you should reduce fraud. Yes, because then you figure out May can't be pregnant and has cesarean. So we should be able to get better with it. And with everybody having unique biometric Aadhaar, we should not have a situation where people can have 4 times, 5 times the same procedure, right? There's only one time there is bet. So should be able to catch all that stuff. So the cheating necessitated you that. But it is possible. If we do it well, we can. As I said, with my model, I think we can. Because it doesn't require any of this. This walking gate to walk. Yes. Yes.
I'm psychology fan player. So I have a very specific history with respect to mental health care.
Yes.
So very limited choice, limited options, and often exclude the outpatient services like sanitary, which is very low. So what do you think can be done to ensure a comprehensive medicine?
So I won't distinguish between one kind of health and now. So whether it's mental, sexual, physical, whatever it is, you're entitled to walk into a clinic that provides the service and get. Why should you distinguish between one and another? That if you're pregnant, you will get, but if you're not pregnant, you will not get. Why? Why should you have something like to say, you can't have mental health service? Every service that is medical, you should be able to. And you should have more of it. There's no reason why we shouldn't have more of it. The reason that a lot of people aren't able to access it is, first problem, information asymmetry. I don't know where to go to find. The kind of stuff that you have online, everybody is a medical and professional. They're very scared. So you have no way of finding out who is qualified to provide this service. So we can start from there. Actually have people who are specialists, who are trained, who can actually provide this service. That will get rid of all those crazy quacks who are thinking they're providing therapy. And they're doing more damage than good. I have friends who do all of these things and come out worse than they have been before. So there's a real problem with that. So if you make it a part service, then you're likely to at least get some standardization. You're likely to be able to get it in a hospital or in a place that is official rather than some place they do on a video call. You're definitely going to get it better. So there's no need to exclude any service. Exclude physiotherapy. Why? By the way, it's not tough. Why should you exclude physiotherapy? I mean, you got a knee replacement, which you paid for, but not with the physiotherapy that comes out. What's the point of it there? So there's no reason to exclude anything. There's actually a good reason to have everything in there. And lots of the hospitals which provide good therapy and care for certain things just don't follow up with this. So, for example, pain. There's no great therapist for pain. Well, everywhere else in the world, it's very important. You take visit to play, post-operative care. We don't have counseling for cancer patients. We don't have counseling for cancer patients' families. We don't have counseling for palliative care, end-of-life care. We don't have counseling for people caring for patients' end-of-life. We don't have it. Even if you can afford it, there is nobody to provide it to you. So it's mainly do stop this taking. And in this category, if you can afford it, sound is not right. It's very hard to find. Only available in some hospitals, the large ones, the good ones, and even there, qualities but vary. So yes, mental health, even for areas that we know very well, we don't do very good. Pay is allowed. We do very badly pain knowledge. Those of you who've been unlucky enough to have needed will discover how ever it is access to opioids, morphine and others is very difficult because the way regulations are built, hospitals are set up, it's law, it's you must say if somebody has to have the key, that has to come, then you have to requisition it, it must be there, then you give it to you, give you only enough for a week, then you come back next week, same process again. Why? Because you're scared that some friend of the bishop will swallow all the morphine. Cannot. Therefore, I can't give it to you. He can only give you this much. So, the fact that it can be abused means that people who really don't get it. And it's a real problem that is cut. So there's that.
What about, how bad are state insurance card? Like in Gujarat, I know there's Ma card. So I'm just like, versus PMJ, how bad?
They're all mostly aligning and to cool. So even those who had separate schemes are all being subsumed into PNJ. There are differences. So there are two fundamental differences. One is what is covered. So certain things covered in the state scheme, for example, Tamil Nadu, which is not covered by PMJ. And the price is different. So there's another problem there, right? The second one which I had in my notes is we don't have uniformity in the country and how we treat. Might seem strange to you. So each state procures a different set of drugs for every ailment. I'm not saying different brands, different drugs. Make any sense to you? Why should every state treating the same thing, let's say diuretics, have a different set of drugs? Some states have 40 drugs to treat diabetes. Me only 6. There are 40. So just imagine what happens. I'm a patient. I go to the PHC or the hospital. They give me the plug. Because I'm focusing 40 of them. All of them I'm going to give them all the time. Yes? If you have 6, we could have 6. But if you buy 10 of this, 10 of this, 10 of this, 10 of this, in some month you would have 0 of something. So I go back next month, I get the same drug, I'm fine. I go back to third, because they will only give you 1 month's quota, right? I go back to third month, then they say, sorry, this is not a deal. We'll switch you to something else. Lots of people can't deal into this switch. If you're on medication, chronic ailment, stay with it. So what do? You go out to the private market and buy it. Instead, if you're only 6, you would have enough of bunch of those things. And you would have saved a lot of money. So it's a project that I'm working on this. We need only 6. And we market it out, every stick. I said some have 40, some have more than 40, which were the 6. Many of them do not work. Many of them are frightfully expensive without showing any additional value. So if we again rationalize that list, as I said earlier, procure what is necessary, at a price that is reasonable, which is what the UK does. It has a National Institute for Clinical Excellence, and they decide what the government should buy. Doctors, the economists sit together and say what they should buy and at what price. They're playing in the market, government's a bit buyer on the market. So government will have a negotiation with everyone as to how to buy. The other problem we found is all the expensive drugs at the end of the chain don't really make me bored. At least in diabetes. They have very little benefit compared to the price we're paying for it. And therefore, very few people will need it. Whereas in the private market, as soon as a flashy new drug comes, the doctor will want to fund it. So they incentivize. Give you the latest, shiniest new drug. And patients think the later one is better than the one they are. Even though they're perfectly alright with the correct one. So you can have a diabetes drug for 2 rupees. The next one comes around at 49 rupees each. The doctor will write that prescription. So the latest, but it is better. Hey, what do you buy? But in the public health system, that's not really true. You have to look at it and say, I think they provide benefit to 99% of our people. So in our treatment protocol, we make sure that after you've gone through this, when you get to that. So if you get to 4 OP, then we put you on that egg. The other concept that I wrote about many years ago, 10 years ago, was that if there are patented drugs that are necessary for our healthcare system, and one example was the first drug for hepatitis C, which affects millions of people, not just in India, but all over the world. And the only treatment for it is a liver transplant. It's frightfully expensive. So the first drug that actually cured hepatitis C, the drug called sofosbuvir. Can anyone guess what price of cake pill of sofosbuvir was when it was launched? Come on, take a guess. $1,000. In money, 28,000. One pill for it's called a $1,000 pill. And need about 84 of those for a course of treatment. And the logic for that course was cheaper than having a liver transplant. So there's not the cost of nucleate, not the cost of research away, not the cost of disease, but value. So we will not price on cost, we price on value. The value of this is still cheaper than liver transplant. Where is essential? You did. We go back to that idea I had about essential, cough and cold. This is hepatic, right? Because people are dying. There's no cure for it, it's the only cure. So that time I go that the way government will deal with it is to put out a tender and say everybody who can make sofosbuvir will tender a price. If the patent holder wins that tender, they get to supply. If somebody else wins that tender, the patent holder will compulsory license to that winner of it and get all he cares. So we're not again commons, we're not nationalized, we do nothing. This is not a new idea. It exists in the Patent Act, it exists in the TRIPS of B. This is not a new idea, I'm not communist. So we can actually get essential drugs, even if they are family kept, for our public healthcare system. Okay, so this is, without is all this theory. Okay. No. We have countries around the world who actually die. And you'll be a little surprised who they are. Guess who appropriated private property. Take some guesses. And those are all communists. Give me some good names. I say, give me some good names. I want free marketeers, neoliberals. America? Strange, no? Free market peoples. Republican Party says we should appropriate private property. Did it during the anthrax scare? Did it during COVID? Told of the world they can't do. So when the pandemic treaty was being negotiated, America resisted all of it, saying that it would be appropriation of private property. But they did it for the vaccines. So think about it when you hear all of these terms that the brave capitalist world loves compulsory licensing. And they benefited from it a great deal from all over the world. And therefore, we shouldn't feel shy. And people who haven't felt shy are the Thais, the Zimbabweans have bravely done for compulsory license. Just imagine. Tiny country, poor country, brave enough to do a compulsory license. And our government chose not to do it. Go ahead. Told the Supreme Court it would be bad for us. People are dying. It would be bad for us if we the compulsory license. And I'm not making this up. It's on an affidavit by the Solicitor General for the Supreme Court. I was present. I have told this. So, yes, it's a cute idea. It works. Others have done it. India takes a very poor stand on it. And the failure of the pandemic treaty at that time, when India and Brazil were supposedly together, largely comes down to this, that we were exposed as hypocrites. We said all these wonderful things, but we refused to do it and are not back here, then millions of people were dying. Didn't make us very neighborly. When I said it at that time, that the treaty would fail, when all this was happening, India and New Zealand, Global South had come together to it. It's on American watch. So we too, I said that Lord Words was very hypocrites. And once we come out as that, World War Day 6, he was lost all credibility there. And that was 10th of May that day. It was in speed order. And everything crashed gone. And the treaty that's come out now is pretty tough. Sort of at that. Okay. Bears? Yes.
I genuinely research in the movie speak.
So yes.
So you just mentioned about cesarean operations as incentivized by cesarean operations act as a X factor for the change. And what there is a barrier in survival perinically that services.
Yes.
So just an inflection of what is so we connect together. So can we say that political will as a barrier is not best existing because of patriarchal nature of society, but also the economic vested interests which are there, because of which we are provided so more facilities at last times causes rates, and again that impacts the humanity which has the wounds.
Yes, absolutely. But also, there's a fundamental problem. I don't know if you were pretty interested would buy Calvin Perez or Invisible Druid. Everybody should be read. And deals with how women are aged. And there's a whole chapter on invisibility medicine. And how healthcare thinks of women. To put it truly, is men without balls. So we don't recognize that they're a completely different way of function. The biochemistry is different. Everything's different. Even for trials of drugs, women are excluded for most of that. If they are included, they're a very small number, and that is not disaggregated. They're just aggregated into the whole. So they're not significant players in the research that we're doing. We don't understand women biochemistry at all. And I spent life in pharma. And the company I work for had several dynamic products. And I say it from that experience that the understanding of women's bodies by science is very poor. Medicine even worse. So we just have a long way to go in saying that women should be included trials. Our thinking about women's bodies has to change. So when they do trials, they don't track which day of the month and the difference in actual body reactions. Whereas the biochemistry changes throughout the month for them. Does not for men. But we don't track. So it doesn't matter. The response is just totaled up. For different women in different points of their cycle. Which actually from a data assignment would laugh and say, come on, this is rubbish, this is not science, how can we do this? That's exactly how science does it. So we don't track it that way. You just total it up, aggregate it across women, irrespective of when that data was collected, the time one. And then we add it to the events data. So it's completely submerged. And then we go clip up and say, this is the RCA. And then we apply that to everybody, uniform. You understand?
And also the representativeness. So, for example, there is a disease which is more common in women, even for those stereotypes as men.
So mostly women are excluded, irrespective of where the disease is. And because we haven't done this study to understand, as she says, the prevalence by women, by region, by communities, we don't do any of that. Which is why you don't see very many women's health products. They just assume that if you have pain, the same thing that works for me will work for you. When it doesn't. And that is the personal experience of a lot of women. It's different kinds of pains, different times of the year, different things that can potentially have different remedies. Nobody's told you anything about it. You get the same 2 or 3 things to go up and down all the time. With paracetamol, Combiflam, Overactive. That's it. Good luck if it doesn't work. But there is a lot more that we can actually do. If we understand better, we can actually work. So, before you do mental health support given during pregnancy, you're like, that small an area, I'm not saying you shouldn't do it. The problem is actually all of the women's health. So, if we can get better research and get better awareness, doctors just don't get it. Serial doctors don't get it. They are suffering. They're not able to translate that into better empathy and better service to their own patients. So, you have lots of problems. Has to start in school, start in college, pretty few during medical education, because at that time they're completely cleaned up and then repainted, right? The whole mind during medical education, any professional education, that's what happens. Everything that you've learned, believe, gets washed out and then gets painted as doctor. And they forget their own personal experiences every day when they were on that lab coated. The problem exists elsewhere. I don't think my model can solve that for me. I'm sorry. It's a bigger problem.